In the next section, we'll discuss the propagation of the action potential down the length of an axon. In this section, we'll discuss action potential propagation. Action potentials often have to propagate very long distances. This becomes an enormous problem for the cell to solve. If you think about an alpha motor neuron someplace in the lumbar portion of the spinal cord, those axons have to traverse, in some cases, a meter or more in length until they reach their final target. Therefore, the length of distance that the action potential has to travel is literally orders and orders of magnitude longer than the cell body itself. This poses some special problems that axons have to solve in order to allow these signals to propagate without decrement from the cell body out to its ultimate target. So how does the axon do this? Well, the first thing to recognize is the challenge that these axons face. And this slide illustrates the decrement of an electrical signal down an axon. So shown at the bottom is a snippet of an axon. We have an action potential on the left side, which is equivalent to injecting a large bolus of charge into that axon. And the pink curves represent what happens to that charge over the length of the axon. Well, early on, there is a large amount of charge, and the thickness of the pink line refers to how much charge is left. But that charge is going to do one of several things. Some of that charge will travel down the axon, which is what we want, but some of that charge will leak across the membrane. It's important to remember that these membranes are not perfectly sealed off to charge. That charge can leak across the membrane to small degrees. There's also capacitative charges that allow the loss of some charge across this membrane. So the challenge then is to maximize the amount of charge that travels down the axon and to minimize the amount of charge that's lost across the axon membrane. Well, the first thing to recognize is that we can quantify how much charge is lost and give this a name. And the way we do this is by simply plotting the voltage over distance. So if you plot the voltage over distance for any point source of charge into this cable of an axon, one gets an exponential function that's shown here. That is to say, the voltage drops off over distance. And one can simply take 37% of the maximum or the starting voltage, look across and see what distance did it take to drop off to that amount, to drop off by that percentage, and that refers to the space constant or the length constant for the axon. The 37% number is just 1 over E, and that's where that came from. So the real goal then ultimately is to increase the space or the length constant for the axon. Well, how can we do that? Well, again, to review, the space constant is just the distance over which the electrical signal drops to 37% of its starting amplitude, and we can increase this value in one of two ways. One is we could increase the transmembrane resistance, R sub n. That is, we can make it harder to lose charge across the axon's membrane, and one way we can do that is via myelination. And as we'll discuss, myelin is a substance that has very little conductivity, and therefore it can increase the insulation across the axon. Another way of doing this is by making the axon bigger. If you make the axon bigger, you'll decrease its internal resistance. There are more potential pathways for that charge to travel. And that's another way of increasing the length constant. So we can do this by increasing the diameter of the axon. And as we'll learn, larger diameter axons do conduct more rapidly than smaller diameter axons because of this relationship. But ultimately, we can do this. We can myelinate axons and we can make them bigger, and that will certainly increase the space constant, but it will not allow this signal to travel without decrement down the axon. So that's really the key question, is how does that happen? How can we propagate this axon, this action potential down the length of the axon? And the key concept to recognize here is we can do this because the action potential can regenerate itself. So how does that happen? Well, as shown in this slide, there's an action potential on the left, This is equivalent to a bolus of charge being injected into this axon. As that charge travels down the length of the axon, as described before, the magnitude of the charge will drop off. But as that signal reaches a fresh portion of axon, which was not involved in the initial action potential, there are sodium channels that are voltage gated there as well. They respond to this voltage fluctuation, which is traveling like a wave down the axon. And if that voltage fluctuation, if that amount of positive charge is large enough, you can trigger a fresh new action potential, and that new action potential will open up sodium channels, and you will get a fresh new large bolus of positive charge in that axon. And that new bolus of charge will now travel down the axon. So you've replaced the first action potential with another action potential at a point further down the course of the axon. And this ultimately is the way by which action potentials can travel theoretically infinite distances without decrement, because you are continuing to regenerate new action potentials. There's a problem with this, however. This is an energetically extremely expensive process. So if one could minimize the number of action potentials that have to fire, that is, if you could space out this the interval between these consecutive action potentials, one can make this process much more efficient and actually faster. It's faster to propagate by the wave than by regenerating this new action potential. And that ultimately is the real role then of myelin, and ultimately of making an action potential or an axon larger. And that is by sealing off the points of exit of charge from the axon. One keeps more charge inside the axon and allows more propagation to occur in the axon, and you can space out these individual action potentials. So if you put the whole thing together, that's shown in the next slide, you can see what really happens. We have an action potential on the left. There's charge that goes through the axon. Ultimately, there's a break in the myelin and another action potential fires, and the whole process starts anew. And if one were observing this phenomenon from the outside in, it would appear as if the action potential is jumping from node to node to node. And these nodes are these nodes of Ranvier, which you've learned about earlier. These are the breaks in the myelin. And it almost looks as if the action potential is jumping from node to node to node. And that's why this phenomenon was called, is referred to as saltatory conduction. It actually is not jumping. This is a continuous signal. If you look beneath the surface, so to speak, in the axon itself, there is a continuous signal going from node to node to node. But from the outside looking in, the signal inside the axon is not observable. Now note the important role of myelin here. Myelin really is the key to allowing the appropriate spacing of these action potentials to occur. And myelin is a major target of multiple neurological diseases. So in the peripheral nervous system, myelin comes from Schwann cells, and these are damaged during Guillain-Barré disease. And in the central nervous system, myelin comes from oligodendrocytes, which are damaged during multiple sclerosis. This next slide illustrates an oligodendrocyte versus a Schwann cell. So on the left, we have a Schwann cell, which is myelinating an axon. And recall, the axons in the peripheral nervous system can be very, very long. Therefore, the relationship between the number of Schwann cells and axons typically is high. That is, you can have multiple Schwann cells innervating a single axon. The relationship is different in the central nervous system. Here, a single oligodendrocyte can have multiple processes that myelinate several different axons. And the myelination process is simply one of taking a cell and flattening out a portion of the cell and wrapping around the membranes multiple times. And remember, since membranes have mostly lipid, there's very little water in these membranes, and therefore myelin becomes a very, very good insulator. Clinically, one can make a diagnosis of the loss of myelin As I mentioned before, Guillain-Barré and multiple sclerosis are two classical examples of the loss of myelin. In the case of Guillain-Barré, one way of making this diagnosis is through what's called a nerve conduction study. In a nerve conduction study, a technician will stimulate one portion of a nerve and measure the response at a distal portion of that nerve. And under normal circumstances, one sees the tracing on the top. The tracing on the top in some ways looks like an action potential, and there's a good reason for that. This tracing is caused by the sum of thousands of action potentials occurring in a given nerve, which has, again, a bundle of a few thousand axons. If one were to do the same thing with somebody with Guillain-Barré, one might observe the tracing on the bottom. The important thing to recognize between these two tracings, number one, is the very much delayed latency of the tracing in the Guillain-Barré patient. This is caused by the drop in conduction velocity caused by the loss of myelin. And this is the main diagnostic difference between normal subjects and patients with Guillain-Barré, and that is they have delayed conduction velocity. The other major difference here is in the shape of the tracing itself. With Guillain-Barré and the loss of myelin, the individual axons are all free to conduct at their own velocities, whereas when myelin is intact, the axons all tend to conduct at around the same velocity. So when one sums up all the activities under normal circumstances, all of the action potentials line up quite well, whereas without myelin and with all the axons conducting at their own velocities, the action potentials don't line up as well, and one sees this temporal dispersion type of pattern. The important point to recognize, however, is that the overall magnitude of the response, which would be measured as the area under the curve, these magnitudes are relatively similar compared to the delay in the response seen in the Guillain-Barré patient. In the case of multiple sclerosis, one way of making a diagnosis is simply by looking into the central nervous system for areas of demyelination and plaque. A major region where one finds demyelination in multiple sclerosis is the corpus callosum, because the corpus callosum is a large structure which carries primarily axons, and these axons which have myelin are a major target for MS. And shown here on the right is a sagittal section using a flare sequence where white corresponds to plaque, areas of plaque and demyelination, and one can observe many of those areas, in this case, around the corpus callosum. Axons themselves have classification systems. There are two major classification systems that are both in major use. The first one is the Erlanger and Gasser classification system, and this is one based primarily on the physical characteristics of the axon, both its diameter, well, primarily its diameter, and ultimately its conduction velocity. And this system utilizes an A, B, C system, where the largest and fastest conducting fibers are given A, and ultimately C fibers have the smallest diameter, and they have the slowest conduction velocities. Subsequent to this early classification system, a second classification system emerged about 30 or 40 years later, and this was focused more on function. It utilizes Roman numerals in order to distinguish the various types, and one can observe here the various Roman numerals and how they correspond to various types of axons. Importantly, there is a pretty close correspondence between the Roman numerals and the Erlanger and Gasser classification system, such that one can learn the correspondence in order to help memorize these various types of axons. At this point, we have a better understanding of how axons conduct their signals, and therefore certain drug targets become a bit more clear, such as local anesthetics. Most local anesthetics work by blocking sodium channels, and it would make sense at this point why this should be the case. If one were to block sodium channels, one can block the transmission of pain signals from the peripheral nervous system back into the CNS. Now, normally when anesthesia is given, it can be given with or without epinephrine, and the main reason for this is that epinephrine will help constrict the local anesthesia to remaining in the area where the drug is applied and not getting into the systemic circulation, since sodium channels are found in many other places outside of peripheral axons. There are certain parts of the body that one does not want to use epinephrine, and these refer to areas of the body that have end organ circulations. Now, examples of drugs that block sodium channels as part of their mechanism of providing local anesthesia will be drugs like lidocaine and xylocaine. Question 6. A 29-year-old man presents with loss of vision in his left eye that progressed over one day. He also has pain upon movement of that eye. You suspect optic neuritis and order a visual evoked response test. What is the expected result? A. Decreased response amplitude over the occipital cortex. B. Delayed response to the occipital cortex. C. Increased pain in the eye in response to the visual stimulus. D. A seizure. Or E. A normal exam. The correct response here is going to be a delayed response in the occipital cortex. This subject likely has optic neuritis, and optic neuritis is an early presenting sign of multiple sclerosis. The loss of myelin that is part of optic neuritis would cause a delayed response in the occipital cortex, but the amplitude of this response should not be altered by a loss of myelin. Question 7. A 59-year-old man presents with progressive weakness and atrophy in his distal extremities. You suspect amyotrophic lateral sclerosis, which is degeneration of motor axons. What is the expected result of a nerve conduction test? A. Decreased amplitude of motor responses. B. Delayed motor responses. C. No change in motor responses. D. Decreased amplitude of sensory responses. Or E. Delayed sensory responses. So the correct answer here is A. Decreased amplitude of motor responses. This subject or patient has a loss of the axons that are coursing through the motor nerves that innervate his musculature. Because of the loss of axons, the overall amplitude of the motor responses will be decreased. However, those axons that are not affected by this disease are still normal and have their normal amount of myelin, so the timing of the response or the latency should not be altered by this at all. So the correct answer is A. Loss of amplitude, because that part has been lost simply by the loss of the number of axons. That concludes our discussion of the propagation of an action potential down the length of an axon.